And as our last speaker, I want to welcome Francois Mion from France to tell us what work we still have to do and how we're going to use the work that we've done in order to improve the London classification. Thank you, Francois.
First of all, I want to thank the organizer for inviting me to this exciting meeting, virtual meeting on the London classification and protocol for anorectal manometry, and especially Mark Fox. And the organizer gave me the task to answer to the question, where do we go from here? And so I'll try to answer to this in the 20 minutes to come. So first of all, some assessments on the London protocol and classification. It is clearly a major advancement to promote the standardization of anorectal manometry and to allow the different centers using anorectal manometry to perform the same kind of test and to speak the same language. This protocol and classification clearly favor the use of high-resolution manometry, which is an important point in order to improve the accuracy of measurements and to be more confident in the results. And finally, this classification is based on the Chicago classification for esophageal motor disorders, which is a hierarchical classification using different parameters found on anorectal manometry. However, one could say that there are some limitations to this protocol and classification that had been proposed by experts in the field. First of all, it's based mainly on expert recommendations. Secondly, it's used for the classification only of standard variables that have been established with conventional anorectal manometry. And these variables are not specific to high-resolution manometry. And finally, there are no clearly outcome data available to assess the usefulness or the diagnostic yield of the London classification. So to answer or to try to answer to the question where do we go from here, I would try to ask to see four points. Is it possible to simplify the protocol? We clearly need standardized rectal sensitivity and compliance measurements. We also probably need to improve the definition of rectal-anal coordination disorders. And finally, I would try to see if it's possible to include in the London classification new measurements, and especially manometric detections of pelvic floor disorders. So first of all, is it possible to simplify the protocol? So the group from Mark Scott in London tried to answer to this question with a retrospective study of 100 recordings of patients with fecal incontinence. Here you have the standard London protocol with the stabilization time of 3 minutes, resting period of 60 seconds, squeeze maneuvers, three short squeeze maneuver of 5 seconds separated by 30 seconds, a long squeeze of 30 seconds, and then cough maneuvers, push maneuvers, recto-anal inhibitory reflex, rectal sensory testing, and balloon expulsion test. And you probably need about around 20 to 25 minutes to perform the entire test. And so in this group of 100 patients, they look at the possibility of shortening the initial period that give information on the resting anal tone and the anal contractibility, donc the squeeze maneuvers. And they look if you could obtain similar results with a resting period of 30 seconds instead of 60, with 2 short squeeze instead of 3, and 20 seconds recovery period between the squeezes instead of 30 seconds. Doing that, you could shorten this period of the test from 165 seconds to 80 seconds. And what they found is that clearly it's possible to shorten this part of the protocol. You see that the classification of patient with normotensive anal sphincter, anal hypotonia, and anal hypertonia was exactly the same, whether you use a 60-second resting pressure or a 30-second periods for the analysis of resting pressure. And with regard to the squeeze maneuvers, this blind almond plot shows the difference between the incremental squeeze pressure obtained during the second and the third squeeze, plotted against the mean of the two incremental squeeze pressure. And you can see that the mean difference is 0. That means that we could probably shorten also this part of the test by using only 2 short squeeze pressure and a resting period of only 20 seconds between tests. It's probably possible to apply this approach for reducing other parts of the London protocol. For example, it may be possible to reduce the stabilization period to 1 or 2 minutes instead of 3. It may be also possible to limit the number of push maneuvers to 2 maneuvers instead of 3. And for example, also for the cough maneuvers that allow to test the cough anal reflex, it may be possible to reduce the number of cough maneuvers to 1 instead of 2, or maybe to suppress these maneuvers, or alternatively to use it only in some cases. For example, if you don't obtain any significant increase of anal pressure during squeeze maneuvers, it may be interesting in these cases to use the cough maneuver to see if the patient is able to increase anal pressure. The second point I wanted to assess was the possibility to develop or propose a standardized technique for the measurement of rectal sensitivity and maybe rectal compliance. Clearly, the experts were not in accordance with this part of the London protocol, and this is clearly shown by the wording of the seminal paper of the international group published in 2019. You can see that you can, for this rectal sensitivity measurement, you can use either an integrated balloon on the manometric probe or a separate system. You can use a balloon capacity with maximal capacity of no less than 400 milliliter. It should be latex-free. You can use different kind of distension, ramp distension, facet distension. And well, so this is not very precise and probably does not allow a very comparable results between groups. So this vague protocol, as proposed by the London Classification, does not allow measurement of rectal compliance, and rectal compliance may be important to assess, especially when you have hyposensitivity. Rectal hyposensitivity may be true rectal hyposensitivity, but also an increased rectal compliance. And similarly, hypersensitivity may be due to decreased rectal compliance. Secondly, rectal sensitivity measurements are very much dependent on the type of balloon and probe used. And this has been well shown by the group of Mark Fox, where they compared results for volumes to rectal volumes to obtain initial sensation, urgency, discomfort, or pain volumes. And they showed that the results were very different whether you used a barostat bag which is infinitely compliant, whether with the standard method or the rapid barostat technique. And you compare this with results obtained with an elastic latex or non-latex balloon with a limited compliance, and there were no correlation between the obtained result. So clearly, a much needed standardized technique in this field of rectal sensitivity and compliance is needed. A third point I want to also assess is the diagnosis of rectoanal coordination disorders and how to become more relevant with the anorectal manometry. So in the classification as proposed in the Carrington paper, the assessment of rectoanal coordination disorders is based on the results of the balloon expulsion test and also on the results of anorectal manometry. And you can see that all the abnormalities observed are classified as minor findings or inconclusive findings, and there are none of these abnormalities that are classified as a major finding that could be really relevant for the diagnosis of rectoanal coordination disorders. We tried in this small study of 95 constipated patients to look at the results of balloon expulsion test and high resolution anorectal manometry and classify the patients according to the London classification. And what we found is that dyssynergia is really a very common and very frequent symptom present in almost all cases. Well, I could say that this is almost normal because dyssynergia is also a finding that is very frequent, especially with high resolution anorectal manometry. Very frequent in asymptomatic subjects complaining of no anorectal disorder. So dyssynergia is very frequent, probably not very relevant. And in our results, we found on the other side that poor propulsion was much less frequent, found only in 11 patients, and only in patients with abnormal expulsion. So from this, we can I would propose that maybe abnormal expulsion associated with poor propulsion may be considered as a major finding instead of a minor finding. And clearly, we need prospective studies with outcome data to show that this proposal may be correct. Another possibility to improve the diagnosis of rectoanal coordination disorders would be to include the lambda shape of anal pressure observed with 3D high-resolution manometry. This is something that is normal when during the anal squeeze maneuvers that has been described by the group of Lee and co-workers. But we have seen that this lambda shape of anal pressure may be also present in some patients during push maneuvers. And maybe that the presence of this lambda shape could be a more relevant sign of dyssynergia. And a few years ago, we looked to a group of 155 patients, constipated patients, and looking at the potential diagnosis of rectoanal dyssynergia, we looked at the patient that had only 3 tests that were concordant for the diagnosis or the absence of diagnosis. Based on, so the 3 tests were digital rectal examination, balloon expulsion test, and the standard analysis of 3D anorectal manometry. Among those 105 constipated patients, 18 had the 3 tests concordant for the diagnosis of rectoanal dyssynergia, and 23 had the 3 tests that were negative, and so were supposed to have no rectoanal dyssynergia, or normal. And looking at the presence or absence of the lambda shape during push maneuvers, we found that this lambda shape was much more frequent in the group of rectoanal dyssynergia patients. And the predictive, positive and negative values of the test were around 73%. So maybe, once again, this lambda shape could be added to the diagnosis of rectoanal coordination disorders. But once again, prospective studies with outcome data are clearly needed also in this field. Finally, I want to see and to discuss the possibility of include in the London classification the detection of some pelvic floor disorders with high resolution manometry. And this could include the perineal descent, intraanal rectal prolapse, and maybe descending perineum. So perineal descent, this has been shown by the group of Véronique Vitton in Marseille, showing that in some patients, during the push maneuver, you can see that there is a clear and significant descent of the anal high pressure zone of more than 2 centimeters. And then when the patient stopped pushing, the zone returned to its baseline position. So this is something that can be that could be used eventually in the London classification. Another possibility would be the possibility to detect intraanal rectal prolapse with high resolution manometry. This has been proposed by Henriette Henrich and the group of Mark Fox on a group of 188 patients with MRI, defecography, and high resolution manometry. And on high resolution manometry, they found a group of patients with an additional rectal high pressure zone during the push maneuvers. And they found that all these patients had also intraanal rectal prolapse on MRI, as you can see here. And so this sign of additional rectal high pressure zone during the push maneuver had a 100% specificity for the diagnosis of intraanal rectal prolapse and a 62% sensitivity. And this has been confirmed also by the group of Véronique Vitton, where they found that the combination of two 3D anorectal manometry parameters, the additional rectal zone and the perineal descent, was a good indicator also of intraanal rectal prolapse with 100% specificity and a sensitivity of 70% as compared to defecography. Also, there may be a possibility to identify perineal descent with anorectal manometry if you see a significant uplift of anal high pressure zone during squeeze maneuvers. So to summarize, I would say that simplification of the protocol, of the London protocol, is probably possible. We clearly need standardized techniques for the testing of rectal sensitivity and probably rectal compliance. We need to change our paradigms for the diagnosis of anorectal dyssynergia. Maybe the identification of pelvic floor disorders with the high resolution manometry could be included in the London classification. And finally, I would say that collaborative studies, including outcome data, are clearly needed to improve and understand better the clinical and diagnostic yield of the London classification. I thank you for your attention.